Hi, everyone, and welcome to a live chat with Nurse Linda. Today's topic is bowel care. Linda Schultz is a leader and provider of rehabilitation nursing and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. Now I'm going to turn it over to Linda. Hi, Linda.
Hi, thank you, Kaylee, and welcome everyone. It's nice to be with you again. Um, Big news coming up. We're a week early in doing our webinar. It's usually the last Wednesday of the month, but today it's a week early because next week is the Reeve Summit. So if you get a chance, you'll want to be sure and sign up for that. There's going to be a lot of things that will be going on there. In fact, I'll be doing a presentation there, but it'll be a little bit different because it will be actually about bowel management. But what I'll be looking for is information from you at home on what kinds of things that you'll be doing. So it'll be kind of a reverse roles. I get most of my best tips and time savers and information from people in the community. So I'm hoping that we'll have a good exchange about things to do and ideas. People sometimes do some little thing that seems like they just started doing it and it started working and it seems like really not so much to them. But then somebody else hears it and tries it and it's like, that is the saving thing that saves their bowel program. So please feel free and join us. I'll be on Thursday. The summit goes from Tuesday to Thursday. So I'll be on Thursday afternoon. So I hope you'll be able to join for some or all of the summit because we had it, the first one was last year. It was in February, right before the big lockdown, before the whole world stopped, it seems like. So that one was in person and it was just so fabulous. So I'm sure this year it will be equally as good and a lot of interaction. So I think that will be a really good thing if you get a chance to do that. As you can see, I'm looking around because I have little notes to myself so I don't forget to say anything. And I have all your questions here on another tablet. So if I'm looking down, that's why I'm looking down. I'm looking at your questions. So we're talking again this month about bowels. Always, every month when we have webinar, we always come up with questions about bowel management. And it's shocking for people to hear this, but a lot of people do their bowel program and they don't really have a lot of issues with it. I know that seems almost impossible when you're a person that does have issues with your bowel program. So hopefully we can get some of the things, some of the questions rectified and maybe some thoughts and different ideas that you can try that might help, your own situation. So really managing your bowels is a 24/7 process. Now that doesn't mean that every single second of every single day you have to be thinking about it, but everything that you eat, everything that you drink, we're talking about going from one end of the tube down to the other. And so everything that you're doing in your life is going to be affecting your bowels. So people know that they need to drink fluid. Sometimes that's restricted because of bladder programs. So, getting enough fluid in to manage your bowels can certainly affect that. But there are other things you can do to get some moisture in your bowels, either through some medications or eating a lot of wet type of foods. That counts as fluid as well. And then following a healthy diet. So get rid of the processed foods. The bowel wants to break down the food so that it can get the nutrients out into your body. Processed food is really kind of already broken down, so it doesn't give the bowel a lot to do. So after a person has neurogenic bowel, which can come from spinal cord injury, people who have brain injury, people who have other neurological disease like multiple sclerosis, Parkinson's disease, ALS, Guillain-Barré. There's just a lot of reasons why people develop a neurogenic bowel. Now, if you have it from spinal cord trauma or brain injury trauma, it's usually more of a sudden onset or it takes place over a short amount of time. With trauma, everything kind of happens very suddenly. With injury, that's just a sharp onset. But with disease, sometimes things evolve. So sometimes, especially people with MS, they have problems with their bowels, but they really don't develop neurogenic bowel until later in their disease process. So for some people, it comes on rather suddenly, and for some people, it's an ongoing process that comes later. Kind of an interesting thing. The other thing that you need to think about all the time is your activity. And so people say, well, I don't walk, so I can't move that much. But you don't have to move a lot. You just have to move a lot to stimulate those muscles in your bowel, or even just to move the gas and the stool along in your bowel. So if you're doing your skincare releases, pushing up in your chair, going side to side, going forward, going back, you can use the tilt motion on your chair. If you can't physically move yourself forward or sideways, be sure and have somebody check with your positioning while you're moving yourself until you get accustomed to doing these things, because proprioception is sometimes affected, and that's where your body is in space. So sometimes people will move forward not realizing that they're moving so forward, and they take a header out of the chair. We don't want that to happen. So be sure that until you get used to what you're doing, that you have somebody close by that can help you if something happens. The other thing is, remember that song, the knee bones connect to the thigh bone and all that. Well, your muscles are all connected in the same way. So when you're propelling your chair, when you're moving yourself in the chair or in bed, you can roll side to side in bed. Or if you're doing range of motion to your legs or having someone do that to you, that's activating muscles, which is activating the muscles that are next to those muscles. So that's all very helpful. I know gas is always a problem because sometimes there's not enough movement in the body and that gas is not moving along. Our bodies are made to move. So we need to provide that movement to them. If we're not doing it on our own, we need to get that movement to our bodies. So moving side to side and doing your pressure releases, not only does your skin thank you, but your bowel will thank you, because it's able to propel waste through the bowel. And part of that waste is move not only by the bowels squeezing, doing that peristalsis action, but also by gas from the waste that's develops from the waste that helps move things through the bowel. So when you're moving your body, that helps kind of eliminate some of those issues with that. So those are the main things to think about. So let's talk about neurogenic bowel. It's a problem with the nerves. You can have neurogenic bowel and be constipated, but neurogenic bowel is not just constipation, it's that the nerves are not working. So some people will say, oh yes, I have constipation. No, it's neurogenic bowel. So be sure that you recognize that there's that difference, because I know I had this wonderful family I was working with, and boy, the mom just, God bless her, she just couldn't understand neurogenic bowel. And so she would call me and she's like, Linda, I'm in the health food store and I'm trying to find a treatment for constipation. Well, you can have neurogenic bowel, which can also have constipation, but neurogenic bowel is a nerve communication problem with the brain. And so treating constipation is not going to treat neurogenic bowel. You have to institute a bowel program to treat that. And, I have yet to meet the person who said, who you go in and say, well, now you're going to have to do a bowel program. And let me tell you how you do this. And I've yet to meet that person that says, oh gosh, I've just been waiting to do a bowel program. It sounds great. Everybody's just kind of like, instead they're like, you want me to do now what here? It always comes to people as quite a surprise. It's not something that's, out like advertised on TV or on one of those doctor TV shows that we hear about. So people are like, what is this? So it is really kind of an adjustment, and we all appreciate that. Having bowel issues can upset the whole apple cart of our bodies. If you have neurogenic bowel, or if you don't, people who have bowel issues always have problems with just, feeling good, quality of life issues. These are all really significant issues. So getting the bowels in order is really good. One of the other things that affects our bowels is our emotional status. So people sometimes, will say, oh, I got really nervous. I got diarrhea. Sometimes people will get upset about something and they'll say, my bowels are in an uproar and they've got constipation and things aren't moving along. So keeping our mental health is just as important as keeping our physical health in regards to bowels. So with that, I know there's lots of questions. And so we're going to go ahead and plow through these really great questions for today. So the first question is from somebody who has a brother who's had spinal infection and osteomyelitis. And then they went through a period of nursing home care, which sounds like it was really an event, and in the middle of COVID, if you can imagine that. So, problem on top of problem on top of problem. It sounds like it was coming from all directions. So anyway, he got a stage 4 pressure injury, which is a very deep, serious pressure injury. And so one of the things that they recommended was a colostomy. Now, I don't know because it's not in the question, but a lot of times a colostomy is recommended for people who have pressure injury that don't have a controlled bowel program, because that bowel or diarrhea gets in that wound and the wound's infected, and then it just, goes on and on and on. It's quite a bit to clear up. Sometimes at stage 4, those wounds have to be closed surgically, but you still have to keep that site clean. So you need an effective bowel program. So they went ahead with a colostomy. And the big question is the colostomy bag will not, is having difficulty staying on. And this first question, I just thought, oh, bingo, let's just cut right to the source. Because sometimes people elect to have colostomies. Now, this was recommended. So this was, there's elective, and then there's medically necessary colostomies. They're the same procedure. It's the same thing, but different reasons why. So this person had a medically necessary colostomy because of this wound. So it could be after the wound is closed up, there could be the potential to go back and close the colostomy. I don't know in this situation, but sometimes that happens too. So first of all, let's just talk about that colostomy bag staying on. And if anybody has ever done wound care, and most nurses have, and we deal a lot with individuals who have colostomies or ostomies. And when you open up the packaging to the colostomy bag and the equipment, this always just rankles my hide, because when you get the instructions and they show the application of how to put the colostomy bag on, they always have the model or the mannequin or the drawing always has a 6-pack. Come on, manufacturers. How many people do you know who have a colostomy? Well, how many people do you know in general who have a 6-pack? They make these bags for good muscle tone, no fat underneath them. And they show the application of the colostomy bag, and it just adheres and it stays on, and it's just so lovely. I don't know anybody whose colostomy bag stays on, and when it comes off, it's always at the most inopportune time, of course. That's like when diarrhea hits, it's the most inopportune time. So they're having problem with that, and they're trying to figure out how to get that colostomy bag on. So a good wound care specialist can help you with that. Things that you want to look for is getting that seal. There's seal around the colostomy bag that fits right around the ostomy. There's a skin prep that you can put on the ostomy, because that's part of the bowel that's been brought forth to the abdomen that creates the opening that the stool can come out instead of coming out through the rectum. There's a skin prep that you can put on that's kind of tacky, that will protect that delicate tissue of the bowel that's now on the abdomen, that opening, and then also make a little tacky area around that. And then the bag has some sticky substance on it, so it just fits onto that right over that colostomy opening. You buy a size of bag that matches the size of the colostomy, so that the stool does not get on the skin. It just goes from the ostomy into the bag. So that is supposed to stick and adhere. Not always does it. Most of the time it doesn't. So there's some other things that they can do. There's a belt that you can wear that will help strap the colostomy on. Some people will use paper tape around the edges of the colostomy to help hold it on. Sometimes, depending on where the colostomy is located, so if you have it on the side of the abdomen, close to the end of the large intestine, just slightly up from where that large intestine is going to enter into the rectal vault, which is where stool is contained before it's expelled. The stool will be much more formed stool, and so it comes out a little bit not as rapidly as if you have it further up on the large bowel. It's more watery, because that's one of the main jobs of the large intestine, is to create the chyme, or the waste that's gone through the small intestine, and the nutrients and fluids been taken out of that. It becomes a little more solid. And so if it's further up, that more liquidy, it comes out at a little more faster pace, and that's a little bit harder to contain. So those are some things. But yes, I validate you and everybody who has them. People sometimes think, oh, I'd like to do a colostomy because my bowel program takes too long. Or, sometimes people elect to have that because the bowel program can be kind of a pain sometimes. So sometimes people elect to have a colostomy so they can select where they want it to be. Now, in this case, that might not have been possible because it was a medically necessary situation instead of an elective situation. So yes, getting that colostomy bag is a challenge. Sometimes there's extra, I'm going to call it glue, that you can put on the colostomy bag and around the skin to help hold it on. Sometimes getting that belt will help hold it on. Sometimes tape. If it's not staying on and you're having consistent problems with it, talk to your healthcare professional about checking with a wound care specialist, because they have a whole lot of tips and techniques, of which, it would be just like too many. Those are the basic things, but they might have something that might be a different product that might work better. They might have a little secret little tip that they're doing, or, they've got a bunch of little tips, but they might know just the thing once they see it and they say, oh, well, this is what you need to do. Or it might be like bowel programs. There's a lot of trial and error to it. So there's a lot of trial and error to figuring that out. But you'll be able to master that, and it will work out, because people who have those colostomies, even without the six-pack, eventually do get that bag to stay on there. So there's another procedure, and I see that somebody's thinking about having a colostomy or some kind of procedure. I want to get back, is interested in an ostomy procedure. Their bowel program, they're annoyed with their bowel program, and so they're thinking about this. And so some people get so annoyed with the bowel program that they think of this as an option. So there are some questions, and I did write a blog about some questions that you might want to think about. So I'm going to try to recall most of them here. So the reason why we do bowel programs is because it mimics the process of the natural bowel function. So we kind of think of the bowel program as being the first line of defense, and with the neurogenic bowel, and then we kind of save the ostomies for later in case there's some kind of problem. So there's a problem. The bowel program is just really, it sounds like, even in a few words, I sense that this person is just had it with their bowel program. And I know other people that are just like, it's a line in the sand. It's over. There, you can get a colostomy. There's another procedure too called the MACE procedure. Okay, if you're familiar with the Mitrofanoff for the bladder, where a little piece of appendix is taken from the belly button to the bladder, and then you cath through that through the urethra instead of through the urethra. Women do that procedure most often, some men, but for different reasons. But women do it because when you're out trying to catheterize, just because of the female anatomy, it's hard to get to the urethra. So sometimes people do that for catheterization. Well, the MACE procedure is like that, but except for the bowels. They take the appendix and they make a little tunnel from the bowel to an ostomy in the abdomen. So there's an artificial opening there, but the connection is through the appendix. So they're not really moving the colon, but they're taking an ostomy and making this passageway now from the bowel to the abdomen. It's called the MACE, M-A-C-E. And what happens with that is you don't have to wear a bag. A lot of people don't know about this, and yet it's real popular in the spinal cord community, but yet still it's not, people just automatically opt for the colostomy. I'm not sure exactly why. So maybe people don't know as much about it as I think they do. But, maybe that's just in my world because I know about it. So, but some people have this. Now, what you have to do is you have to irrigate through this ostomy, but you don't wear a bag. Sometimes stool can be expelled through that ostomy, but most of the time it's set up so that it's not. So you have to do this irrigation to get the stool out, but that's all you have to do. So maybe that's why people don't like it, because there's something you have to do there instead of just collecting it in the bag. But there's not as much odor. You don't have a bag that breaks. You don't have all this trouble of getting the bag on. If you're thinking about some kind of ostomy, think about both of those procedures. Think about us having if you're a person with neurological disease or injury, think about surgery. A lot of people are spinal cord injury or not. A lot of people think, oh, I'll just have the surgery and it'll be all better. Surgery is very serious with neurological disease, especially spinal cord injury, no matter how low it is, because of breathing issues. I have had patients, and this I don't mean this as a frightening sort of thing, so I probably shouldn't say it, but now I've started. Sometimes people will elect to have the colostomy, and that procedure, they actually die. That's very few, but it's a risk. So you need to think about the risk and the benefits. So that's pretty serious. You also need to think about, is there anything else that I can do in my bowel program? So one of the things that that I see is that people do the suppository, or maybe they move to the mini enema, not a full enema, a mini enema. That's Enemies or Theravac makes these mini enemas that work just in the rectal vault. And they stimulate that peristalsis, and they help bring out the stool. It's not a flushing of the stool. That's not the normal stool action, but it stimulates the mini enemas, like the suppository, stimulates the natural action of the bowel. A lot of people, as I say, this is a shock to people to do this procedure. So they just stick the suppository in, or they just stick the tube for the mini enema in and let the chips fall where they may. Both of those products have to be placed up against the side of the bowel wall to work. If it goes in the middle of stool, it just stays in the middle of the stool and you don't get that bowel action. So if you have a higher level injury in the cervical or thoracic area, you have to remove that stool that's in there so that the suppository or the enema can work. And that seems to me to be the number one thing that I see, where people just, oh yeah, I put it in there. Well, if you put that in the middle of the stool, the body heat's not going to melt the suppository, or it's just going to sit there contained in the stool. It's not going to move to the bowel wall, and so that's not going to work. So that's another issue. So go through and check your whole bowel program. But now after 17 years, I understand that this person is having an issue. And so, these are just important considerations. But think about all the benefits and risk. And sometimes when you're at 17 years and you're frustrated, sometimes, the risks don't seem like very much. And so, but, just think about it before you do it, because it's a major operation. So you want to be sure that you're well prepared to go into that. Also, be sure and check with your payer, because sometimes in elective colostomies, they don't pay for the supplies after you have that procedure done. Sometimes they won't pay for your ostomy bags or things that you'll need. So you'll need to know if you'll be bearing the cost of that, or if they will pick that cost up. These are little things to consider, because that can make quite a difference in your life. On to this next question. Here's a lady who has a daughter who has Prader-Willi syndrome, which is a genetic disorder, but they also have a C1 incomplete quadriplegia, and they feel like they're held captive in their house because of bowel movements, and they want to try to do a bowel program to kind of get this under control. So you'll want to talk to your healthcare professional, because with that C1 incomplete, there can be different situations that are going on. So for people who have cervical or thoracic spinal cord injury, we call those upper motor neurons. The motor neurons control all the movement in our body. So my head moving, my blah, 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 talking, my fingers moving, walking, bowels, any movement in your body is controlled by these motor neurons. The upper motor neurons are actually located in the brain, and they stay within the central nervous system, except for a few way up here in the head that like work your eyes and smell and stuff like that. Those are cranial nerves, and they do come out. Motor nerves do come out of the brain, but mostly they stay within the brain. And then they also have long arms that reach down into the spinal cord, but they generally do not leave the body except for up here. But they will connect to the lower motor neurons, which is what we call when somebody has an issue in their lumbar or sacral area. The lower motor neurons do come out and connect to the nerves of the body. So sometimes with those incomplete injuries, or if it's not something like a spinal cord that we can say, there's the spot, with things like disease kind of issues, you can have an upper motor neuron injury, you can have a lower motor neuron injury. The uppers has a lot of spasms, so the bowel is spasm, the sphincter spasm. The lower motor neuron is represented by flaccid tone. There's no tone at all, usually at all. But in disease process, you can have one or the other, or you can even have a third option of a mixture of upper motor and lower motor. So the type of bowel program that you would be doing would be different. So in the upper motor neuron, which at the C1, you would think it would be, maybe not, because it's a disease process. But with the upper motor neuron, that's usually the one where you give the stimulant, suppository or mini enema, followed by digital stimulation, and then to relax the sphincter and get the bowel peristaltic action to push that stool out. And then that's the process. With the lower motor neuron, you usually just do manual removal of stool. But so your healthcare professional will be able to tell you which of the bowel programs that should be on, because that would be really important to know. But yes, probably a bowel program would be in order. Now, there might be something, because these bowel movements are so unpredictable, you would think bowel program, but being that it's a genetic cause, if you didn't know about the incomplete cause, if you weren't thinking about the C1 incomplete, and you might just think of a toileting schedule where every 2 hours you toilet. So, that might be an option too. That might be the bowel program, is to toilet regularly. So those are some options that you can talk to your healthcare professional about that. We're going a little bit onto a different subject here, but do you have any tips regarding healing pressure injury? So this person had a broken hip and sacrum, and they didn't operate it at the time. And, last month I mentioned this, there's this old way of thinking that people who have spinal cord injury don't need to have broken bones set, or they don't need to do anything because you're not going to be using those legs anyway. Ugh, I could just, yes, but you still need your skeletal structure, and you still need to be prepared for the future. You still need to do range of motion. This person is having problems seating because their bones are out of alignment, and now they've got a pressure injury because the bones weren't set. So you always should have, some people will say, oh, we don't need to set that bone, and you can insist, yes, I do want that set because you need it. If you decide you want to do standing as an exercise, or if you decide you want to do one of these new procedures where people are getting some implants and they're getting some feedback to their nerves, and even if you want to do range of motion, but you can't do range of motion because your bones are out of alignment, and so it's causing more trouble, you need to have your skeletal system in place. So anyway, they're in the process of getting custom cushions, and they're doing this. Any tips on the healing process in the boning area where the sun doesn't shine? Well, now this is the part that people don't like. The way you heal up a pressure injury is to not put pressure on it. So not sitting on it, not laying on it, not having rub up against the side of your wheelchair. And people say, oh, I've got to go to work, I've got to go to school, I've got my life. I can't just lay in bed and heal up this pressure ulcer. But that is what has to happen. If you're putting any pressure on it, the more pressure you add, the more the injury stays the way it is. That's why pressure injury is from pressure. They changed from pressure sore because they thought that people were getting the idea that they were doing something that was causing the sore, and they're trying to take that stigma off. Pressure injury happens because the bone is pressing against the inside of your body on the skin. So you can do pressure releases to help that. But once a pressure injury is started, you have to stay off of it. Now, sometimes people have surgery to clear up pressure ulcers because they become so bad. And the problem with that is that once you have surgery, you cannot lay on that area for 6-8 months. Absolutely not, because the skin's been open to do the surgery. It's trying to heal. It's already has injury underneath. It's a big process. And people who do that, they all come back. I will never get another pressure injury because I'm not going through this again. I've learned my lesson about doing those pressure releases. So certainly, staying off of it. Sometimes people, well, I just got up to brush my teeth, or I just got up to do my bowel program. If you're putting more pressure on that injury, you've negated all that time you've stayed off of it. So that's the icky side that I always hate telling people, because nobody wants to hear that. But staying off of it, even if you have cushions, they reduce or disperse pressure, but they can't eliminate pressure. There's gravity. Nobody can eliminate it. So staying off of it is the key. So sorry about that piece of news. How to manage hemorrhoids with spinal cord injury. Again, another bane of people's existence. And a lot of people think I get hemorrhoids because I do digital stim or do manual removal. Using generous supply of lubricant. And by that, I don't mean it, how the lubricant just drips all over everywhere. It can be so messy. So sometimes people just put a little, you just need a little tip on the end of your finger and then it will coat the glove. Not necessarily. Sometimes that glove is, pretty dry at the base of your finger. If you put the lubricant here, sometimes it doesn't come all the way here. Sometimes people put the lubricant at the rectal opening and use that. If you use a generous supply of lubricant, your rectal tissue is inside your body. Anything inside your body really doesn't want you touching there, but you can. with a gloved finger with lubricant to make sure that you're getting the glide across the tissue and not tearing it, not putting pressure on it, not damaging it. So use a lot of lubricant. There are different kinds. The regular stuff that you buy is that real goopy stuff. There's another lubricant called Astroglide. Whatever lubricant you use, be sure it's water soluble. If you use other things like petroleum jelly, those are not water soluble, so it just stays there and makes a gunky mess. And so avoid those. But regular Surgilube or Astroglide is not as goopy. It adheres better. It's a little more expensive. So the Surgilube is fine, but that's, just another option. So if you do that, you shouldn't really have too much problem with hemorrhoids, although like anything, they can occur. It's not necessarily something that you did. But I'm just saying that is a tip to use a lot of lubricant. Now, if you have the hemorrhoids and they're out of your body, so they've come out of the rectal area, you can take that lubricated finger and put them back in, push them back in where they will stay moist. The rectal vault has moisture in it. And so that will help them stay moist. Once they come out and they get very dry, that's when people have a lot of problems with itching and they're uncomfortable. You might not feel those sensations if you have problems with sensation in that area, but you could have spasms, you could have AD. People who have lower level injuries sometimes just have this, weird feeling because something's wrong, and it's these hemorrhoids that are drying out and causing problems. So that's the first thing to do. You can try using the old Preparation H and keeping them moist, or there's some little cold, it's almost like a piece of gauze, but it has some fluid in this little pad like thing, and you can put them on there. It has a cooling feature to it, but it also helps keep those external hemorrhoids moist. So if you can keep them from drying out, that's a good treatment. The other thing about hemorrhoids is sometimes they have to be removed, but if they do, you want to have, you don't want to have that surgical cut of those hemorrhoids. You want to have the freezing procedures work better. That's come out in the new Tux pads. Thank you, Tom. That's exactly the word I'm looking for. Thank you. It's funny how your mind works sometimes. It's like, yes, that's it. Those are great too. So if they get that bad, but most people, if they catch them early on, they can shrink them with the Tux, with the hemorrhoid cream. Now, if you're prone to constipation, or if you're doing manual removal, you want to be sure you have a softer stool. You don't want that stool to be so hard, because that rock of stool is going to scrape up against that delicate tissue. So Tom also says he keeps a bottle of witch hazel, which is, that's an old thing. My grandma used to use that, but I keep it in my house too, Tom. I use it for all kinds of things. It kind of tends to shrink vessels up. It works really well if you're a teenager and you get a acne or something. You can put that on there. It kind of reduces that a little bit too. So it's an old-fashioned kind of treatment, but hey, it works for some things. So you can pretty much manage these, and you can pretty much get them down on your own if you catch them early enough. So think about some of those treatments and keep that stool soft. Use a stool softener if you're not using one, to keep that stool from getting that rock hard, constipated kind of effect. Any study available for paralyzed people waist down? Oh, yes. Lots of studies for all kinds of individuals with paralysis. You can go to clinicaltrials.gov, and any trial that is sponsored by government funding in the United States and in other parts of the world will be listed there. Now, if you find a study that you think you would be interested in, but you can't travel there, or there's some kind of issue that's going on, or it's just out of reach because you have to go 6 times to New York and you live in California, it's kind of an impossibility thing. But you can take all the information from those studies posted, what they're thinking about, why they think that this might work. And then after they do the study, what their findings are. So that's a good place to educate yourself. Then you can go to your physician and say, I know you're not doing this study, but what do you think? Can we adapt this to my care? Do you think this would work for me? And then sometimes they're able to do those kind of things. Now, if you have those lower level injuries, there are some devices that are available now that you can have implanted on the nerves outside of the spinal cord that help with bowel, bladder, and sexual function in males. And those are FDA approved. So that is something that you can get. You have to find a person who knows how to do it. There's not every single surgeon knows how to do these, but if you work with companies and, that provide the equipment, they can direct you to somebody. And there's a clinical trial fact sheet up there in case you want more information about that. Here's somebody who has a high level incomplete and they have sensation. They don't have a bowel program, but they rely on their sensation to go naturally. Sometimes because of foods, as the period's longer, if nothing happens by day 4, I use a suppository. How many days is too long? Well, in complete injuries, we recommend every other day. In complete injuries, we say some people need to keep continent. They need to do their bowel program every day. People who have that lower level injury might just, every time they toilet, they might just check their bowel because the sphincter there's no tone, so stool can drop out at any time. So they just keep their rectum empty at all times. But usually with the complete injuries, we say every 3 days for people who don't eat much. It's kind of 2 days is the rule, but sometimes we'll say 3 days. Now with incomplete, you have some sensation, so you know what's going on there. So for 4 days, if that's working out for you, 4 days would be fine. I don't think I would go longer than 4 days because you don't want to get too much buildup in there. And the longer that the stool stays in the bowel, even in the rectal vault, that bowel is constantly working. And what it does when it works is it's pulling nutrients and water out of the stool. So the longer it stays in, the harder it becomes. The harder the stool is, the more it tends to rip and tear that delicate bowel tissue when it's coming out. And you don't want fissures or hemorrhoids or all that to start. So if it's happening, if it's working by day 4, your stool is still moist. There is this thing called the Bristol scale, and you can just look up Bristol scale. It's all over the computer. I talk about it all the time. It shows you pictures. It's cartoon pictures, just drawings of what stool looks like when it's constipated, what it looks like when it's diarrhea. It gives us a way to talk about stool. Some people have a loose stool and, oh, I had diarrhea. No, diarrhea is just water. That's just watery stool. But you don't want constipation. You don't want the loose. You don't want the loose stools. You want right in the middle, a nice soft form BM. And they have two pictures drawn out of exactly what it should look like. So look up the Bristol scale. They also, everything has an app for that. Can you imagine? There are bowel trackers. Now, these developed mostly, I feel, because of people with irritable bowel syndrome who are tracking these kind of things. The Bristol scale actually has an app where you can track your bowel movements. So that might be a good idea. You can rate what it was according to the scale. You can put when you had it. And there are other bowel trackers as well, and they're free. You can just download them onto your phone. So it's kind of neat in a way, because especially if you have multiple caregivers Or if I were to go up to you and say, hey, a week ago last Wednesday, what was your stool like? You'd be like, well, I don't know. But with Bowel Tracker, you can know. You can see how long you've gone. It just kind of helps, especially if you have multiple caregivers or if you're having trouble regulating your bowels. You can take it to your healthcare professional and they can kind of look over your charts and make recommendations. So if it's working for you, then that's fine at day 4 because of the incomplete and because you have sensation. Now, for people who have complete injuries, I would say, no, that's way too long. So, okay, which brings us to the next question is prolapse. And this is something that happens. It doesn't happen a lot, but it's people who have neurogenic bowel are at a higher risk of having rectal prolapse. And that's when the actual lower part of the bowel comes out of the rectum. So it kind of falls. And what happens with that is that the bowel floor, you have to excuse me for just a second. When the bowel floor becomes lax, so there's not a lot of muscle action, and this happens after paralysis. Yes, there's not a lot of muscle action in your legs or maybe even up in your arms, depending on where your injury is. But the bowel floor becomes lax too. And when we're sitting, our rectum is actually supported by the surface we're sitting on, unless you're on the toilet or the commode. And then you've got that ring that you're sitting on, and that bowel floor tends to have nothing to support. So the tissue tends to drop out over time. Doesn't mean that you're going to get it, but you are at a risk of it. So you have to think about that. So that's the cause, is that the muscles in the bowel floor. Now you can strengthen your bowel floor muscles by doing your range of motion activities, moving your legs. That helps move those muscles. So that is helpful. Some people will do some e-stim to strengthen their bowel floor. And some people will have to have surgery to have the condition corrected. So those are some of the causes and the treatments and the remedies. Now, doing digital stim or manually removing stool, does that contribute to rectal prolapse? It can, because you're kind of pulling in that area to try to get the stool out. So those are just some of the issues, but one of the ways you can prevent it is to use if you're using a suppository, to put the suppository in and then wait the 10 to 15 minutes before it starts working, before you sit on the toilet, so that you're not sitting there so long. Sometimes people, I know people who sit 3, 4, 6 hours on the toilet or on the commode waiting to have their bowel movement. If you haven't had your bowel movement, if you put your suppository in, wait, after a while, you'll know how long it takes for you to have your suppository work. If you're putting it against the bowel wall, it's going to take about between 10, 15, sometimes 20 minutes for the Ducalox suppository to work, because it has a vegetable coating which has to melt, which won't melt unless it's against the bowel wall, because it melts by body heat. Suppositories melt by body heat. So do the mini enemas have to be up against the bowel wall. Everything's got to be up against there. So some people put in their suppository, they don't get any results because it's not doing anything. It's not against the bowel wall. It's like the number one problem. The other thing is that wait until you're then the magic bullet, which is the complement to the Ducalox suppository, doesn't have that vegetable coating. So it melts a little bit faster if it's against the bowel wall. So that can be in about 5 minutes. So get to know about how long it takes for that suppository to work. Then get on the commode or toilet. Do your dig stim. And then that should only be for about 20, 30 seconds that you're doing DigStim, and do it gently, gentle, gentle, gentle. When you're doing digital stim, you're trying to relax the inner sphincter. And the next question is about that in DigStim. The inner sphincter is in the people with the cervical and thoracic injury is usually spasm and is closed tight. The point of digital stimulation is very gently to do that digital stimulation so that you're relaxing that sphincter. Now, sometimes you can, it's about the fingers, it's about 3 inches. So it's about a finger's length up. Sometimes you'll feel it relax. Some people never feel their inner sphincter because, we're all different. And so some people's are a little higher, some people's are a little lower. But as long as you're doing close to that area, you don't have to be on the inner sphincter, but if you're nearby, it will relax if you're slow. Now, again, as I say, people are shocked by this whole process. They want to get in and get out. And so they start doing that DigStim as fast as they can. Well, think about spastic muscles. If you have a spastic muscle in your arm or leg and you start really doing the range of motion exercise, it's going to spasm more. You have to be gentle with spasticity, and you have to be gentle with your digital stim. So those people who are being very aggressive with that digital stim are stimulating more spasticity. Excuse me. Once you get that tickle, it never goes away. Okay, so that is the deal with that. So be very gentle with that. When you're doing manual removal, be very gentle to avoid prolapse. Changes as you age. Well, the bowel slows as we get older, and you've got a neurogenic bowel, so it's slow anyway. So again, looking at your activity, looking at your diet, looking at your fluid intake, those are the things. Some people don't have any problems as they age with their neurogenic bowel. Some people might have to add more products to try to maybe increase their stool softener, or they might have to add other kinds of products. Now, psyllium, this is one of the new changes in the guidelines to neurogenic bowel. One of the issues is that we used to give psyllium, Metamucil, fiber, all those bulk formings. For people, especially with the higher level injuries, we would give that, psyllium, and lower level injuries is still okay to do psyllium if that helps you, so don't worry. But for those people who had the higher level injuries, and I would always put this in my blogs when I would talk about it, take it. But if you can't take the recommended amount of water with it, you're making a concrete brick in your stool, because it's got to have, psyllium's got to have the fiber laxative, has to have about 8 ounces of water to keep it working throughout your bowel. I go to a lot of hospitals, I go to a lot of nursing homes. I see people taking psyllium. I have seen people measure out the psyllium in one of those little medicine cups, and then put a little water in there, stir it up, and be like, oh, here's your fiber. Oh my gosh. So that's just made a little clog in the bowel. It's made a little rock in there. Now, some people would take their fiber and they divide it up so they'd have a little bit, because they'd be on bladder programs and they can't take in 8 ounces all at once because they have to keep their bladder from overfilling and backing up into their kidneys, which is a huge problem. So they would take a little bit of psyllium here and a little bit of psyllium. They get the dose in by the end of the day, which would be fine, but it wouldn't be just all at one time, but they were just always drinking it. So if you can't take the amount of water with it, they're recommending that you don't do it because you're just working against yourself. So if you're a person have a higher level injury in the cervical or thoracic area, you're taking psyllium, but you're not taking the correct amount of water with it, talk to your healthcare professional because they can switch you to higher milligram of stool softener. They can switch you to other products. You don't want to just stop it automatically. You want to, see what you need, because your bowel may be relying on it. Maybe it's been working for you. Maybe it's been fine for you. So talk to your healthcare about that. Let's see. This one, we're coming close to the end, so I'm going to end with this one, because this is just so true to life here. So we're living in a time where it's likely we're going to see quadriplegics start to be able to use their hands because of new technology. And older quadriplegics would tell me they were told yes right around the corner repeatedly and to no avail. And yes, yes, yes. So scientists, people like me, we so believe in the cure that's coming, because we have seen testing and trials, working with Christopher Reeve. That was a big, huge turning point in my mind. Certainly there were a lot of experiments and trials that were going on with cures, but it seemed to me like the big line in the sand, the big turning point, came with the Christopher Reeve study, where we started looking at a lot more cures versus rehabilitation strategies. So a lot more looking at return of function. Now, I'm not saying people didn't look at it before, because certainly they have looked at it all along. But that just seemed to be, because of, I think, the publicity, and, there was just a big flurry of trials using electrical stimulation, aquatic therapy, even incorporating more standing into people's therapy, using the robotics, that kind of kicked off the exoskeletons. It was also the time of stem cells, which are still being studied. It's kind of taken a little bit different path now with the stem cells, but they're still actively working on all these things for cure. And I just wanted to bring up, if you get a chance, at the University of Washington, they've taken electrical stimulation. Now, this is just, I think, so cool, because it's just like somebody saying, hey, what about this? So we all know about the surface electrical stimulation, where they put electrodes on and people ride the bicycles, and you can put them on your arms. There's implant studies going on. There are implants that have been around for a while that have given people functional movement. And so that, there's just all kinds of things going on there. But anyway, this group at the University of Washington in Seattle, that group of people, that somebody there said, hey, instead of putting the electrode on the individual muscle on the surface of the skin, what if we put the electrode right at the back of the base of the, well, not quite at the base, but right at the back of the neck? What if we put the electrode right over the spinal cord? And this is using a handheld device, so it's not, real elaborate kinds of equipment. But if you get a chance, and you can look this study up, again, it's at the University of Washington in Seattle. And they put that on people who had tetraplegia, and they gave them some therapy, and they said, let's see if this improves hand and arm function. And it was just like within a short amount of time, like within a couple of weeks, people saw huge differences. And over time, they just got more and more adept at this. And so, it's like somebody said, hey, instead of let's putting it on a muscle that will stimulate the muscle, that will stimulate the nerve, that will go to the spine, that will do, let's just put it right over the spinal cord, like they're doing with the epidural stimulation, but on the skin, not inside the body. And by golly, so, when you see these big strides like this, it's hard to believe that a cure is not right around the corner. I know some people, and right around the corner, by that I mean within my lifetime, I think that we'll see phenomenal strides. Not like tomorrow afternoon, but it's, it certainly is coming. So I'm really excited. I mean, right now, and for the last 10, 20 years. It's just been really exciting to see all these things. Now, when you're the one that's waiting, I realize one day is too long to wait. And I get that. But when you see all the things, how far people have come and all the things that are going on, it's really fantastic. So yes, I would imagine that's what this person is talking about. Are we going to see quadriplegics start to be able to use their hands because of new technology? Well, this is not new technology, but it's technology used in a new way. And, you know, it's going to be financially relevant. It's not one of these things, well, you know, I've got to get my payer to get $30,000 for this, or, you know, a robotic machine costs this amount of money. I mean, this is the kind of thing that is, you know, is happening now. So look up on University of Washington quadriplegic arm improvement, and you probably can Google that. You can probably get their report. You can then take that report to your doctor, because e-stim is an approved therapy. You could take that report to your healthcare provider and say, hey, what about this for me? And you might be able to duplicate that process in your own rehabilitation setting. So we're talking about, wow, you know, this is something that is, oh, and it's in the chat box. There is, well, Zach, you're right on top of it. So Zach's got the connection right there to that study. And I've recommended it to a lot of people, and several people have connected with them. They've gone to their healthcare professional. They're trying it out, not as a clinical trial, but as a therapy, because e-stim is an approved therapy. So, you know, it's like, how marvelous is this? It's got so many facets to it that's going to be helpful. So anyway, that's really great. And it's 3:00. I hope that some of you will be able to join us at the summit. Any part of it will be great. It's always good speakers. The list is wonderful. And I hope to see you next month. Thanks so much for joining us.